All right. Hello, everyone. Welcome to the Lown Institute's Fair Share Spending Launch. My name is Vikas Sani, and I'm president of the Lown Institute.
I'm Judith Garber, Senior Policy Analyst at the Lown Institute. We're so glad to have you all here to discuss how nonprofit hospitals are giving back to their communities.
This is the third year that we're offering the Lown Hospitals Index. It's a groundbreaking program that's the first to measure social responsibility in the hospital sector. We created this ranking because we believe a radically better healthcare system is actually possible, but only if we have the right data and the metrics to guide the changes that we need. So the Lown Hospitals Index includes metrics that haven't been used before, like racial inclusivity, avoidance of overuse, and pay equity. Today, we're talking about fair share spending, which evaluates how much hospitals give back to their communities compared to the tax benefits that they receive. And it is tax time, and you all will have to be filing yours pretty soon, so it's timely.
Nonprofit hospitals play a vital role in improving community health. Not only do they provide essential medical care, but they also give free care to uninsured patients, and they offer services to the community like preventive health clinics. And in addition, hospitals are also increasingly investing in the social factors that determine health before people even go to the hospital, factors like nutrition, housing, and education.
Now, I think most of us know that the COVID pandemic showed how important these types of social investments can be. Communities with less access to primary care, with higher rates of chronic diseases, and with crowded housing and poor housing were disproportionately vulnerable to COVID. And as I think many of us know, many of these were communities of color. Just as hospitals stepped up to care for patients with COVID, it's just as important, we believe, that they address the slow pandemic of health disparities and chronic illness that's impacted communities for decades.
For private nonprofit hospitals, spending on community health is not just a social obligation, but it's also a legal one. So as Vikas mentioned before, taxes are almost due. And while you and I might be dreading having to pay them next week, nonprofit hospitals are exempt from most taxes. And this nonprofit tax exemption is a huge financial benefit worth an estimated $40 billion in total. In return for this nonprofit status, we require hospitals to report spending on charity care and other community benefits.
However, many hospitals don't invest a comparable amount into community health as they receive in tax breaks. In fact, some give back barely any. So we created a measure, the Fair Share Spending Measure, to see how much hospitals are giving back. If hospitals spend more than the tax breaks that they get, they have a fair share surplus. If they spend less, they have a fair share deficit.
For this measure, we look at community benefit spending from hospitals' IRS Form 990, Schedule H. We include only categories on the form that have a direct and meaningful impact on community health. So these categories include financial assistance, which is also known as charity care, contributions to community groups, community health improvement activities, subsidized health services, and activities that address the social determinants of health. And on the other side, we estimated the value of the nonprofit tax exemption at 5.9% of total expenses, which is based on previous research from Johns Hopkins University.
So, how do hospitals perform on fair share spending? Before we get to the results, let's introduce our guests. First, Dale R. Folwell, CPA, is serving his second term as State Treasurer of North Carolina. Treasurer Folwell is responsible for the state pension fund and the state health plan, which is the largest purchaser of health care in North Carolina. In this role, he's been an advocate for greater transparency on hospital prices and fair financial assistance.
Jennifer Valenzuela brings nearly 20 years of experience building and supporting teams in the healthcare sector to her role at Health Leads, where she oversees the organization's people, culture, and equity strategy. Prior to Health Leads, Jen served as director of the Young Parents Program at Boston Children's Hospital. As a licensed independent clinical social worker, she also worked in the emergency departments of Boston Children's Hospital and Brigham and Women's Hospital.
And last, but definitely not least, Dr. Paul Hattis, a physician attorney who joined the Lown Institute as a senior fellow after retiring from his role as senior associate director of the MPH program at Tufts University Medical School. He's a member of the faculty of the Department of Public Health and Community Medicine there. Over many years, Paul's policy-oriented research efforts have focused on the issues of hospital accountability and on efforts to advance consumer advocacy on healthcare costs and system-wide affordability. So let's get started. Our first question is for Treasurer Falwell. Mr. Falwell, you pay for the state health plan in North Carolina. Do you feel like North Carolina hospitals are paying their fair share?
That's a great question. And let me say what some of you may have heard in the past. When you see one treasurer's office, you see one treasurer's office. North Carolina's treasurer's office is uniquely constituted. It's one of the largest pools of public money in the world, nearly $250 billion. But about $3 billion of that has to do with our being the fiduciary for those that teach, protect, and serve by providing healthcare and pharmaceutical benefits for them. And this all started with us about 3 years ago when I attempted to find out what we were spending our $3 billion on. I asked UNC Healthcare, which is also the state hospital. I'm the state treasurer, they're the state hospital. I asked them to send me a price list so I could figure out not what they billed me, but what we were supposed to pay. So I know how energetic everybody is at this point in the afternoon. So I'm getting ready to show you the master charge list that was returned to us by UNC Healthcare. And not only am I their largest customer, I'm the largest customer of every member of the cartel in North Carolina. So here we go. In case you didn't get that, Jen, let me show you again. Every single page was redacted. The fact is, this is an industry that wants to continue to operate in secrecy. And we could have a whole nother panel about transparency. But the fact is that the reason this is important to me is that we don't know what we're getting for what we're paying. We're constantly told that we're subsidizing other things going on in these entities. And one reason that the cartel will not work with us to correct this is that because of all the charity work they do. Now, as you'll probably notice in a little while, in parts of my life, I used to stutter more than I do currently. Why do I use that strong word cartel? The reason is that when I was attending Winston-Salem State and UNC Greensboro, I was told when I was struggling to find just the right word to go to the Webster's Dictionary or possibly the Bible. Cartel is defined as an association which is formed to restrict competition or raise prices. We have seen the cartelization of healthcare in North Carolina because they control the supply of healthcare through the certificate of need. If you were to pronounce the first letter of those three words, it would leave your lips sounding like con. It's a con because they control the supply of healthcare. They control the access, the quality, the price. And now we have found out that they also control whether they want to destroy your credit rating if you don't pay for this product called healthcare that you would rather not have consumed, and no one would tell you ahead of time what it cost. So we took one of these pieces directly to your question about charity care, and we provided the data to Johns Hopkins University. Johns Hopkins University came in and came out with a report that you can read on our website that talks about the fact that these entities are receiving billions of dollars of tax benefit in North Carolina. No sales tax, no income tax, and no property tax, and only providing a few $100 million worth of charity care. So the whole notion that they need to continue to operate as secret corporations, disguising themselves as nonprofits because of the charity care they're offering no longer holds water.
Thank you.
Thank you.
Thank you. Let's get some of the other speakers in here.
Sure. This question's for Jen. You work with many community organizations, and some of which get funding from hospitals. So we know hospitals are doing good work in communities. And what are hospitals doing well, and what more could they be doing?
Sure. I do think the hospitals are doing their community health needs assessments. That's now part of the ACA that has to happen. And so they are now starting to hear the voices of the community members more than I think what was happening before. And that's happening in a uniformed way. I think they're starting to recognize the different topics that may not be the hospital's priorities, but is their neighbors or community members or patients' priorities. So I do think they're doing better on that front and getting access to the community. I think they can do better. I think Treasurer Fowle, you're just saying like the dollars that can be contributed to the communities and to the states of where they are, it could be better. And I think you're going to be sharing some numbers in a little bit about how big those deficits are. So.
Yeah, we will. Paul, you've been writing about the Boston hospital sector. We've heard a little bit about North Carolina. How relevant is this topic of fair share spending for the Boston market, or really for any market for that matter?
Well, first, thanks for inviting me. And here's what I would say. As someone who, even to this day, after many years of thinking about hospital accountability and community benefits issues, does believe that there's value in a nonprofit healthcare sector, and at the margin, I want to believe that the decisions and the efforts of those kinds of institutions make our society better, especially in the healthcare world. Having said that, though, the accountability issues, including ones that Dale pointed to, are real, and therefore the Lown Institute's looking at the Lown Index and different measures of accountability makes a lot of sense to me. But as someone who worries about affordability of healthcare in Massachusetts, about market expansion leading to impacts on lower price, lower margin providers being able to make it. Those are all current worries in our scene. But the community benefits issue, which is long-standing been a focus in Massachusetts, is also an important one. And I think while in our state and like the federal government, it's mainly focused around a reporting obligation, it's really ultimately about hospitals and how they engage with and then impact communities for improved health status. And I think the resource commitments that they make around that are important. And I think the discussion today will talk about aspects of that. So thank you.
Great. So let's get into some of the results. So at Lown, we measured fair share spending for 275 nonprofit hospital systems. And those are groups of hospitals organized as single entities. And this is about 1,800 hospitals in all in these 275 systems. And for most hospitals, the data is from 2019. So what we found was that nonprofit systems spend less than you would expect on charity care and community investment. In fact, 82% of hospital systems had a fair share deficit. So if you add up all the fair share deficits of these hospitals, the total is $18 billion.
We want to show you a list of the 10 hospital systems with the largest fair share deficits. You may recognize some of these hospitals. Are some pretty big names here. Number one on the list with the largest deficit is the Providence Health System, and they operate in the Pacific Northwest. Their deficit is more than $700 million. And you can see that this whole list and the top 25 in surplus all on our website right now. So not only do a lot of these systems have huge fair share deficits, some of them also received hundreds of millions more in taxpayer funds through CARES Act funding the next year in 2020. So for example, the Cleveland Clinic Health System took $423 million in CARES Act grants. And at the end of the year in 2020, they posted a $1.3 billion in surplus revenues. And this picture is of the hospital in Abu Dhabi that the Cleveland Clinic spent $2.5 billion to build.
The University of Pittsburgh Medical Center took $761 million of COVID funds. as they reported a $1.1 billion in surplus revenues. By the way, this is a rendering of the new UPMC Presbyterian Patient Tower that's scheduled to open construction this summer and will be open for business in the fall of 2026.
And number 14 on our fair share deficit list, Northwestern Medicine took $289 million in CARES Act grants in 2020, and they ended the year with $814 million in excess revenue. So we also looked at which states' hospitals had the greatest total deficits. In 7 states, the total fair share deficit exceeded $1 billion. For each state, we added all the hospitals with a fair share deficit together to come up with these numbers. California, as you can see, has the largest total deficit at more than $2.5 billion.
So these are some striking numbers. Let's hear from our guests. What do you think about the numbers themselves? Do you find these results surprising? Jen, why don't we start with you?
Those are some big numbers. I think I'm surprised at how big these numbers are. But I'm really disappointed, I think, overall, as I see this and I see this lost opportunity that we have. I also, hospitals have an opportunity to make a really significant difference in communities where they are. These numbers tell us that they're shortchanging their community, they're shortchanging their patients, and their neighbors that they say they are currently supporting. And I think there's a lot of things that we could do across this country if these dollars were put to use. I was looking just last night, and it's estimated from the Department of Housing and Urban Development that if we wanted to end homelessness in the United States, estimated cost would be about $20 billion. We're not far from being able to cover that. And what would that be if we could actually make those changes within our country? If we ended hunger, it's a little bit more, about 25 billion, but just think of what we could do with those dollars.
Thanks. Paul, let me ask you something. I mean, maybe with these numbers, it's easy to bash hospitals. When it comes to community benefit spending, how much is actually within the hospital's control?
Sure. Here's my take on that. First of all, it's a little bit unfortunate, but it's the history of community benefits that we tend to look at the value of inputs rather than the value of outcomes. I mean, if we're discussing quality of hospitals, we wouldn't be talking how much does each hospital spend on its quality efforts, but really we'd be talking about the outcomes of what happens to patients objectively as well as patient-reported outcomes. The community benefits arena finds its origin tied to tax exemption, and that's why we tend to have a conversation that's built around the inputs. Having said that, and having sat on my community hospital advisory committees, what I've often said is, look, charity care demanded on you is a function of the availability of insurance in the state. We sitting here in Massachusetts, we actually have the lowest uninsured rate. It's also a function of where you are geographically in a community where there's going to be a lot of charity care demanded on you by who shows up to your emergency department, or are you not? So in some ways I say, look, your ability to control that number, if you want to call it that each year, is limited. But what you do have control over is what I call more your programmatic community benefit spending, both the amount of it and how you spend it. And there's an effort these days to try to get hospitals appropriately, given the equity challenges we have in society, given the overall health status challenges, to spend those dollars more in a preventive sense, sometimes referred to as upstream. And that's where I like to focus the conversation. Now, that doesn't mean the dollars don't matter. And with this, in 2016, I and a colleague, for example, in our own state of Massachusetts, did a detailed analysis of community benefit spending then, and it really hasn't fundamentally changed. And we were disappointed to find that over half the hospitals in our state didn't at least dedicate 1% of their expenditures to do the so-called programmatic direct community benefit spending. And then one more thing I want to offer, which is when hospitals do account for that, part of the complexity is that spending doesn't it sounds like the average person that those were monies that are going outside the organization to support different activities, but that really isn't the case. In an accounting sense, if, for example, I spent $100,000 that I reported on a food insecurity program, it might well be that 70% of that, as an example, is my own staff in the hospital who are, working on aspects of setting up the program, and only 30% of that maybe is going outside the hospital. So some of the community benefits reporting is really just, in many cases, taking hospital expenses and salaries and recategorizing them. And so I think that's part of the complexity of this measurement aspect of the whole effort.
Thanks, Paul.
We wanted to ask you, Treasurer Falwell, so the North Carolina's total fair share deficit is about $450 million across all hospitals that had a deficit. So what does this deficit mean to you as state treasurer? What would this money be spent towards?
That's a great question. It's not only this deficit number you're mentioning, but it's the impact on those that teach, protect, and serve. Before most of you were born, there was a saying we used to use called making ends meet. We're now in a situation right now with healthcare that ends will never meet. People are not able to see themselves out of their poverty because of things associated with healthcare billing and healthcare spending, and the weaponization of healthcare billing on people and their credit scores. Ultimately, what it means to us is that a beginning teacher or a beginning trooper may have to work 1 week out of every 4 this year to pay the family premium associated with the largest purchaser of healthcare in the state. My wife says, to put these things in context, the context of this is the size of the North Carolina State Health Plan is nearly equal to the domestic employment base of Buffett's Berkshire Hathaway, Diamond's JP Morgan, and Bezos's Amazon combined. That's how much buying power we have. And this is not just as far as the fair share deficit that you brought up, but the ultimate impact on deductibles, co-pays, credit scores, and then people just having a general sense that they can't afford to get sick. And when you get in that type of vortex, then obviously the cost of healthcare goes up for everyone else. But people not being able to see themselves out of their poverty because of fear about healthcare billing manifests itself, in my opinion, in this fair share deficit.
Thanks. Jen, you already addressed this a little bit, but maybe to be more specific, since the Massachusetts scene, the Mass General Brigham's fair share deficit is over $600 million. Knowing what you know in Eastern Massachusetts, in the Boston area, for example, what could $600 million do for Boston communities?
A lot. So the fiscal year 2017, the governor's budget for homelessness services, so for emergency assistance, family shelters, the services that are available, was less than $200,000 for FY17. So while Massachusetts—
I'm sorry, you said 200,000.
Oh, I'm sorry, 200 million, 191 million, sorry.
Okay.
So while we know that the system is imperfect, I do know that Massachusetts has a pretty well run and a really good services around homelessness compared to some of the other states that are out there. But imagine what we could actually do if we had 3 times the amount of what the governor was requesting by just one health system contributing to that pot. We could make a really huge impact on homelessness, the crisis that we're facing in Boston and across Massachusetts. I still occasionally work in the emergency department, and the number of families that are coming in looking for somewhere to live, it doesn't end. It's continuous. They're living in their cars, they're bouncing from home to home, their children can't be in school consistently, they can't keep a job because they don't know where they're going to be the next day. There's a real impact on our communities. I think another idea, what could you do with $625 million with just one system? Mass General Brigham is actually our largest employer for Massachusetts residents. They employed over 73,000 people in 2021. And so one question would be, what if they just raised the wages for their lowest paid employees by just a couple of dollars an hour? If they took that amount and divided it by those who are at the bottom, what could happen for that population? What could happen as far as their buying power, as far as being able to provide and purchase the foods that their household needs, their physical health, their mental health? Maybe it means they only have to have 2 jobs to survive instead of 3. Still maybe not making ends meet, but being able to live a little bit healthier. I think that impact would be pretty significant across the state, and it wouldn't take a lot of staff to be able to make something like that happen.
Thanks. Paul, you know, in our fair share numbers, a lot of red states did well in part because they have a lot of charity care. And the reason they have a lot of charity care is they didn't expand Medicaid. But let me ask you, many of the ones with the largest fair share deficit are in blue states. So what does that tell you? Is there anything there that might be worth talking about?
Well, I think what it points to is that there, unfortunately, has been the trend around the country, including in the blue states, as you noted, that as charity care demands went down from the ACA, including Medicaid expansion and other ways of trying to cover people, the thought was going to be that there would be a commensurate increase by hospitals in community benefit spending on the so-called direct programmatic side, subsidized healthcare services, upstream, kinds of investments, whether it's in affordable housing or food insecurity, et cetera. And we just haven't seen that. And that's been the reality since the ACA passed, back in, 10 years ago now, and then implemented across the country in 2014. It's also true in our state of Massachusetts that we have not seen sort of as charity care has gone down, really the replacement on the direct programmatic side. What we're interested though in Massachusetts is not only getting that additional dollars put forward, and there is varying capacity amongst the providers in our state to be able to do that. But as I alluded to, our Attorney General redid our guidelines a few years ago to try to learn how much of it actually is going into so-called upstream issues. And the answer from the first couple of years since those guidelines have changed is still not enough. It's still small relative to the overall spending, at least as reported by the healthcare institutions. So I think those are some of the things that I and colleagues who worry about social determinants of health or social determinants of equity would really like to see.
Yep. So we have a few questions from the audience. Maybe we can pose some of those. Here's one for you, Treasurer Falwell. I mean, it could be for any of us, but really, are we seeing any impact of consolidations in the hospital community in terms of what that does to community benefit spending? Is that something that we can talk about?
Well, I think we are. I can't answer for all the other states, but we have seen a massive cartelization and consolidation of healthcare into the hands of fewer and fewer people in North Carolina, especially over the last 5 years. And we know that is resulting in lower quality, lower access, and higher cost for North Carolinians. So that consolidation is definitely happening. And what's so ironic is that in the North Carolina Constitution, which is this little book right here, it says perpetuities and monopolies are contrary to the genius or the a free state and shall not be allowed. Healthcare now owns North Carolina, and Big Wall Street now owns healthcare. And this is what we're observing in North Carolina that's resulting in lower quality, lower access, and higher cost, and the weaponization of people's credit scores. And the reason this is so important to me is that all of our jobs are to advocate for the invisible. A lot of people don't know this call's happening. They don't know I'm the state treasurer. They don't know who you are, but that's not what's important. What's important is that we know who they are and how they're suffering. And this is not just on the healthcare side, but it's also on the prescription drug side as it relates to drug adherence. So these are all very important issues that are happening, especially in North Carolina, especially over the last 5 years. We have one nonprofit in North Carolina that has $9 billion in the bank. They didn't make that by selling widgets or creating software. They got all of that money on the back of sick people. $9 billion in the bank. To put that in context, that's 3 times more than the state debt or for the whole state of North Carolina. And we have seen massive mergers. HCA took over Mission Health, all the healthcare west of Hickory, North Carolina toward Asheville. Novant took over one of the few independent, profitable, high quality, high access, low cost hospitals in Wilmington, merging the Greenville area east of 95. And then of course, Atrium taking over Wake Forest Baptist Hospital. This is just a few of the transactions that we've seen over the last few years.
Great. A quick question for you, Paul, from the audience. I think you're probably the best to answer this. Is there a way we can ensure that certificates of need or disproportionate share spending can ensure effective community benefit spending?
Certificate, well, so disproportionate share payments are payments made to hospitals that have high uninsured and Medicaid burdens, just to help them sort of make it in the patient care function. And I look at that as more of, can a hospital just make it to do its patient care mission separate apart from its community benefit mission? So I'm not sure, unless people say, gee, we want to find that, if you are, there's some hospitals in our state that seem to both have high, Medicaid burdens or are also doing his best efforts or good efforts on community benefits. We want to supplement them in that way. And our certificate of need, we call determination of need in Massachusetts, is more focused on effects on the market, on competition, and worries about overall state spending increasingly these days and pricing. What I would say is, if we're to start with this issue, and whether it's Dale, or Jen speaking to various aspects of the challenge that exists, whether it's just people affording healthcare and health insurance, whether they're welcome in an organization, whether the billing and collection practices are fair, those are all things that go into accountability. But since we're talking about fair share today, one of the things that's gaining some traction around the country is this whole discussion of payment in lieu of tax payments. And I think if you sit and think about it, and this has to do with the fact that municipalities, towns, and cities, which don't collect property tax from larger charities, have to then get it from individuals and businesses who do pay taxes. And I think when you look at the fact that police, fire, and street and sanitation in a good number of our cities is often 25% of the budget, and nonprofit hospitals get real value from those municipal services, to not ask them to at least pay that portion of the property tax to help pay for those services seems sort of crazy to me in this day and age. And so therefore you're having discussions, I know in our state, not only in Boston, but in some other communities in and around the country, about asking, even when hospitals, nonprofits are tax exempt overall, that maybe we ought to at least modify that and expect them either voluntarily or involuntarily to at least pay about a quarter of what their property taxes would have been for services they actually receive. And that seemed very much like a fair share argument, to say the least. So
great. Now I'm going to throw one from the audience to our own Judith, resident expert. Do we see any differences in types of nonprofit hospitals with regard to fair share spending, i.e. church affiliated, secular, some other type?
We haven't done a direct comparison between these types of hospitals, but I think it's worth noting that on our top 25 list and even our top 10 list, you see a lot of the very large Catholic system, Providence, Ascension, Dignity and Catholic Health Initiatives, which is now Common Spirit. All those are way up there. And it may just be because they're very, very large systems. But I think that's something that's worth taking a look at. We also had a question about whether we can include government health systems in this analysis. Unfortunately, because they don't file the same IRS Form 990, we can't make that exact comparison. However, we do include them in our charity care ranking on the Lown website, which you can take a look at and even do a little ranking in your area or to see how everything measures up.
There's another one. What objections have been raised regarding your methodology? I think I can address that a little bit. So I think the things we're hearing the most are, well, it's misleading. You're not counting enough stuff. And in particular, let me say, there are some things we don't count. We don't count dollars spent on research. We don't count dollars spent on training physicians. Both of those, I think, are because in large measure, research and training are actually paid for, and it's not at all clear. Certainly, it's not transparent, and we're not sure at all how to account for those. Not saying those things aren't important, but is this the place to be accounting for them? And the other one is Medicaid shortfall, which is the difference between what it costs a hospital to take care of patients and how much they get paid by Medicaid for those patients. That's a difference, and that difference is filed with the IRS as a community benefit. And we don't agree with that. We're not saying it's not important or that issue and the issue of Medicaid coverage isn't important. Hospitals obviously do a lot of great things and they should all be accounted for, but just not here. So what we're trying to measure is the things that are directly, meaningfully of benefit to the communities. Paul, I know you may have a thought on the Medicaid shortfall piece.
Well, I'll add this thought. I mean, when Medicaid was started, it was always understood that the reimbursement rate would be less. I'm gonna get a little bit wonkish here than average total cost, but really just cover what they call the variable cost of caring for Medicaid patients. You know, and what I often say when I talk to hospitals who say, well, you know, our shortfall, we get paid 70 cents on the dollar. I said, well, part of that problem is if you cut your expenses by 10%, and it might look closer like you're getting paid 80 cents on the dollar. So part of the shortfall is a function of the hospital's own, you know, expenditures. You know, and people have argued, look, hospitals do understand that this is, you know, a contractual obligation of theirs to care for the larger community. What I would say, though, and I think is a fair discussion argument, is that when the Medicaid proportion reaches a certain level, you know, and maybe this ties back to disproportionate share hospital concern, you know, there may be, if we want to count community benefits in the way that we do, you know, then maybe for certain hospitals, when it's above a certain threshold, say, sure, because we know that that's going to be an additional burden that really is going to impact your overall ability to dedicate resources to community benefits. But I wouldn't necessarily say that's true for everybody. All I can tell you is in Massachusetts, when we've looked into this with our Attorney General, had large, you know, broad-based discussions about it. For many years now, Medicaid and Medicare shortfalls are just not part of the reported calculation for the reasons you gave, and some maybe that I added here as well. So.
Yeah, thanks, Paul. Yeah, I agree. I think we need to move on, but I will say I think you know, there's a lot there to unpack, and there's a lot of technical detail that we're happy to get into. But I should point out that our fair share deficit and our community benefit index does actually factor in the payer mix, the proportion of Medicaid. And so in that sense, we are trying to factor that in realistically we're just not taking that gap between expenditures and income as gospel. So we really should spend some time on solutions. I think we really want to see how we can catalyze conversations that could actually improve things, improve healthcare. So, firstly, let me just ask a generic question, and let's just go around quickly. Maybe we'll start with you, Jen. But that is, are hospitals actually getting away with something here, or is it really the case that we're asking too much of them? Is it too much to expect hospitals, whose job is actually acute care, too much to expect them to be improving community health?
So I think healthcare systems are for health, not just sick care. And so if you look at it more holistically, that it's more than just the Band-Aids and the surgeries and the emergency department visits, that it's also about preventing sickness and illness and keeping people well, then I think it is part of the broader mission if they are about health. Do I think we're too hard on them? No, they're massive. They're massive entities in this country of ours. They rule the amount of power they have. I'm gonna speak for Massachusetts because that's what I know the most about. The amount of power they wield in the state is quite remarkable. And so with that kind of power, I think comes responsibility. And so no, I don't think we're asking for too much. I think, like, does the formula need to be looked at? Maybe, but also does our government need to do a better job of ensuring that fair amounts are being spent out into the community?
So let me just ask you a quick follow-up. So
Sure.
are there specific ideas or even general ideas for policy changes that you think would really move it forward in terms of improving the health of patients and communities?
Sure. I think there's a few things that could be considered. And I'm sure Paul has lots of ideas on this too. I think you all had some suggestions too, but from top of mind, I think one, the enforcing some simplicity. So these dollars go out to community organizations. There's these requests for proposals, and they're very complex. It is rare to find the health systems to give their community benefit dollars in a way that is simple and that is trustworthy of the organizations, believing that they know what needs to happen for their community. So simplicity. I think there's an opportunity for pooling the funding, so that it's not the hospital being able to control what it is that they're supposed to be giving in the ways that they want to give it. What if we were able to have it be put into a centralized pool, a trust, with a neutral entity that was able to do some real community engagement around what's needed within all of the different communities across the different states? And so imagine what would that look like if we had less of the one or two focus groups that I think hospitals currently do to say that they're receiving that understanding of what's needed, but really true engagement where there's dialogue, there's discussion, there's debate, there's prioritization, where community members are making the decisions and helping decide where those dollars are going. That policies that allow for that and that set that up would completely change where the prioritizations are and what the programs are that are getting developed. And so, and I think there would be things created that we haven't even imagined yet, because I think we've left a lot of voices away from this process that are missing from the conversations.
Thank you so much. Our questions for Treasurer Falwell. What kind of policy changes would be helpful for your state?
Well, thank you. Number one is to get rid of secret contracts and push the power down to the consumer. We've done that with our clear pricing project. We have 27,000 providers who have said no to secret contracts. They publish their prices in a way that the average person can understand. And while doing that, we actually exalted the reimbursement rates for primary care physicians, mental health specialists, and physical therapists. My initials are DR Falwell. My wife sometimes accuses me of talking as if I'm a doctor, which I'm not. But I'm saying that to tell you that I think that those three specialties are the ones that are closest to the health and well-being of our community and have the best opportunity to keep people out of hospitals. That's what we're trying to do in North Carolina. is keep people out of hospitals. I did want to say before I close, to Paul's point, if you were to leave Raleigh and go to the Outer Banks of North Carolina, you would go through Terrell County. There are less citizens in that county today than there are students at Myers Park High School in Charlotte. Less citizens in a whole county than one high school. Why should you care about that? Because you're exactly right, is that when these low and fixed income people pay their property taxes, and the other folks, the nonprofits who don't pay property income and sales, which fund public education, public safety, public works, and public roads, that burden gets shared, especially among lower and fixed income people. And I know I'm going to run out of time, but I do want to tell you, which is kind of breaking news, I'm personally in collections. 2 years ago, last week, I was one of the early contractors of COVID. Had a very small chance of living in March of 2020. So when I talk about these subjects, I'm not talking about healthcare workers. I'm talking about the multi-billion-dollar corporations and their multi-million-dollar executives. The reason I say that is last fall, I had a follow-up image done. 8 minutes, $6,000. I was there for 8 minutes. I paid $500 point of sale. It ran through the state health plan. And I've purposely put myself in collections because I want to see how the average person in the state is being weaponized by healthcare billing. And so I'm in collections, and because I want to see how many text messages, how many letters, and how many phone calls I get every day trying to collect this bill, which I could pay at the snap of my finger, because this is what's happening to our average citizens.
Have you been offered one of those credit cards that'll charge you an arm and a leg, but it'll pay your medical bills?
Yes, stay tuned for more to come on that. This is the brochure. Funny you asked. This is the brochure that's called Access One. We have about $75 million worth of these credit cards outstanding in North Carolina. We're going to have more to say about this in the future. But here we're talking about people who should be entitled to charity care. And according to Rice University, peer reviewing the Johns Hopkins work that we did, should be entitled to charity care. Last thing they need is a credit card that has a lot of fine print in it. So stay tuned for more investigative work out of State Treasurer's Office regarding this topic of credit cards.
Great, thanks. Paul, here in Massachusetts, I think a lot of us in the healthcare sector pride ourselves on being very forward-thinking. I don't know how true that is, but with regard to improving meaningful community benefit, what have we done in Massachusetts? You've been close to that process. And what more could we do or should we do?
Right. Well, we've made some improvements on the reporting side, not quite enough. So for example, there's some of us that say, gee, when a hospital reports that it spent, $100,000 on asthma prevention or chronic disease activities overall, and they give us a list of 12 activities, it'd be nice to know how much they spent on each of them, because you get a sense of the seriousness of the investment in each. The other thing that we've made progress, interestingly, during COVID, but we tend to forget it, after emergency periods are over, maybe we won't this time around, is, we got our hospitals day in and day to day talking to each other during the height of the COVID first surge about beds and ICU demands and moving patients around and planning and sharing of equipment. And, it was a real spirit of cooperation. But can you get hospitals to come together and talk about how they're going to really work, collectively towards food insecurity, or about investing collectively in, both affordable and workforce housing? And you can't, and so I guess what I'm saying is I'm hoping that this notion, and this has been talked about in our community benefits discussion, can we, with carrots or sticks, expect hospitals to work more collaboratively together so that whatever they report spending, it goes much further. They're not sort of doing it in a redundant kind of way, but really in a way that shares both the expenditure, but maybe the sum of the part, the whole is greater than the sum of the parts. And we haven't seen too much of that, but maybe COVID will spur that on, because they saw how important it was to work collectively then when they were, under the challenge, and maybe that can carry itself forward is a thought that I have.
Thanks, Paul. Yeah, so let's get to some more audience questions. But before we do, I just wanted to let everybody know about our next launch, which is going to be in May. Then the topic is going to be low-value care or hospital overuse during the COVID pandemic. So we're going to unpack a little bit about what happened during COVID to low-value care. So keep your eye out for registration for that. And you can subscribe at louninstitute.org/subscribe and get on our mailing list so you'll get notified of the event.
Thank you. So here's one of our audience questions. There have been studies showing that for-profit hospitals provide about as much charity care or maybe more as tax-exempt hospitals do. So one could ask, why not just make all hospitals for-profit hospitals, or eliminate the tax exemption? What would be some of the downsides of eliminating this nonprofit tax exemption? Why keep it?
Paul, why don't you start and then we'll go around.
Sure. We've been debating in this country ever since 1969, when the federal government switched to the community, or the IRS switched to the community benefits standard. What does that really mean? And there's been all sorts of studies showing at times nonprofits do a little bit more charity care than the for-profits, sometimes less. But I think the thrust of the question is there's a lot of us who've defended nonprofits and defended the concept of tax exemption. We've been disappointed that breathing life in the community benefit seems like it's been harder than it should be, and this notion of taking on health status improvement and addressing issues of equity, things that you would expect that the nonprofit would be doing in distinguishable ways, probably overall, than the for-profit, not just in terms of dollar spend, but in terms of engagement with the community and seriousness of time and attention to it. Yes, it's been disappointing. There are moments where I wake up some days and say, maybe we should get rid of tax exemption and then just give credits back for the right activities that we really want, and let's just get rid of blanket exemption. Other days, I think, no, if we can, I do believe that the ethic that exists with nonprofit healthcare, which says that at the decision level, we're not going to make a decision that's just about maximizing profits, but a decision that has, embedded in an organization, has a mission, is sort of still how we want to organize healthcare. But I would say increasingly these days, I wake up on different days that have polarizing points of view. So I understand the frustration there. So,
well, I can't resist just pointing out or adding in that so many nonprofits, to those of us in healthcare in the know, understand that many nonprofits kind of are indistinguishable in their behavior from for-profits. So if you want to maintain that kind of social compact about what it means to be nonprofit, I think they got to up their game. So
I will say, go ahead, Treasurer
yes,
Falwell.
Treasurer Falwell.
I wanted to add that this whole system lacks competence, lacks transparency, lacks accountability. I know there's a lot of things that we would all agree on, but there's one thing I can absolutely be sure of, that we all know that something's wrong with the system. As the sole fiduciary of the pension plan, which is on the second floor of our building, we literally have nonprofit hospitals coming in and talking about their 1% profit margin. And 2 hours later, I could be in another meeting with a hedge fund to buy a nonprofit hospital and convert it with a 20% internal rate of return. How do you get a 20% internal rate of return on an entity that somebody was just meeting with me earlier that talks about they only make a 1% profit? And there's been a lot talked about in North Carolina, Prognosis Profits, which was a Pulitzer nominated piece by the News and Observer about 8 years ago. That's now been refreshed. I recommend you all go to it, theassemblync.com. They just did a 7,000 word expose about the cartelization of healthcare in North Carolina, theassemblync.com.
Thanks.
I
Judith,
also
more
want-
questions?
Sure, yes. So are there state or federal audits to determine if nonprofit status is being met? So this is more about how can government regulation help change how solve this problem?
I don't know if there's ever been a hospital that lost its tax exempt status for solely because it didn't provide enough community benefits, broadly speaking. I mean, there's been issues around, board self-dealing and private enrollment. I don't want to get too legally technical about, nonprofit law, but nobody, to my knowledge, has lost it because somebody said, when we look at the hospital's behavior, they don't provide enough community benefits. So I think that shows you at some level, there really isn't a standard, an ultimate standard by which somebody is judged. And, I guess the only thing I would say there is maybe government isn't the best one to do it. Maybe we ought to have a joint commission-like process. A number of us 30 years ago thought about it this way, where there's site visiting done by an accrediting organization, not the Joint Commission necessarily, but who really would have with it people who have been actively engaged in this effort on behalf of hospitals, and really go in and do what the Joint Commission does in a quality sense, which is aids people towards continuous improvement. And you have to earn that accreditation, which would at least maybe give more time and attention than hospitals do now. But that's a thought about this oversight issue. So,
Could I ask a follow-up? So in Oregon, they passed some legislation, I think a few years back, that would establish minimum community benefit spending levels. And they did it on a per hospital basis, sort of using the hospital's previous charity care and their financial standing to give them a base level of spending. Do you think something like a spending floor or a minimum, is that too strict, or does that bring hospitals down to the floor? Or could that be useful to bring hospitals at least to a certain level of spending?
Well, maybe Dale has a thought about that first, since he's a treasurer of the state. So
I would, my neighbor for a long time in Winston-Salem, North Carolina, was Maya Angelou. And she used to say, when a man shows you who he is the first time, you should believe him. I don't think these nonprofits are going to change their stripes. They're corporations that are disguising themselves as nonprofits. And there's absolutely no accountability. They control everything from the chambers of commerce to the halls of Congress. And it's going to be just like the 60s, where the positive changes that came through our country during that period of time came as a result of people writing the music. We've got to keep writing the music about what is immoral about healthcare billing and things associated with the access to healthcare.
Thank you so much.
I guess I would say sophisticated hospitals always find ways to meet whatever accounting standards or levels are placed upon them. I'm not saying it's impossible to find, some threshold that people would meet, but I'm not sure the body politic would be willing to create such a threshold. So when you create these tests, I think hospitals and their accountants find ways of showing that they meet them. So.
All right, well, we're out of time. One last question. Maybe Jen, this is for you, though anybody else is free to answer it as well. Can we think of non-legislative tactics, things that employers, insurers, or even community organizations could do to ensure that nonprofit hospitals are really meeting their obligation?
That's a hard one, because I think there's such a power differential between the health systems and your community organizations. I think the dollars that they do contribute are significant for the community organizations. And so they're in this real bind where you can't complain. You have to be grateful for what you're receiving. And so to fight current systems is pretty hard. I mean, to be here and to be talking about this, what is that for the partnerships that we have? And so I think, I do think I mentioned this earlier, having our community at the center of these conversations, and for their voice to really have power and to really resonate for our legislators to ensure that those voices are being carried through. that can carry power. They are voting, right? They do know who their legislators are and who's coming in. And so how can there be some better partnerships to ensure that those big power players in our states maybe have to share a little bit of that and give up a little bit?
Thanks. Well, we are out of time. If our guests can stick around, that we have a lot more questions, but I think we'll end the formal part of the presentation now. So everyone feel free to leave. But if you want to stick around, we've got a few more minutes and we have a lot of questions that we can try to tackle.
Thank you, Lowen Institute, for doing this.
Thank you for joining us.
Nice meeting you, Treasurer.
All right. Judith, you want to look at some of the other ones with me?
Sure. Let's see. So this is sort of related. So apparently this is a major election year in Massachusetts. A lot of offices open. And how would ideally this issue be discussed in campaigns? This is kind of interesting, more political question.
Jen, you want to take that one on first, or you want? Go ahead.
Well, you've been one of our governor candidates is actually who their office has been a lot in this. So I think, Paul, you've been closely related.
Well, I'll say this. I mean, I don't know. Maura Healey, who was the Attorney General running for governor, I know has spent time, because I was part of an advisory task force of hers to redo the community benefit guidelines. So she's been thinking about it. We have three new well, at least three on the Democratic side. I'm not sure how many on the Republican side running for Attorney General. This might be an interesting question for them to see if they want to take the guidelines even to a new level. I don't know if this will consume much of the gubernatorial campaign interest, but the whole hospital healthcare spending and accountability set of issues certainly should, and maybe this will be part of it. I don't know. So Jen, maybe you have some additional thoughts about that one.
Well, I think we just, for the first time, had our health policy commission, what's that C? Commission Council reject the expansion of our biggest healthcare system in Massachusetts. And so that was big.
The public health, well, they actually haven't voted yet, but the staff has recommended to our state's public health council, and in the face of that, the Mass General Brigham withdrew its ambulatory care application as of this date. Yes.
Now, the not unintended consequence, but what would have happened with that expansion would have been quite a bit more dollars going to the community. Massachusetts has an additional type of community benefits called determination of need, where when a capital is built, that there's a percentage of that cost that goes back, has to go back to the community. And so that is millions of dollars that now is not going to go to the community. And those dollars, I believe, are much more regulated, and they come through.
Well, let me comment on that, because I have battles with my own consumer friends over this. What you're mentioning is Massachusetts is unique in that when you do a major capital project in our state, 5% of that capital building project has to go outside the organization on community health investments, okay? And for many community groups who want to be the recipients of that money, that's real money, because it's actually, the hospital actually has to spend it. Community benefit dollars, as I noted earlier, a lot of that's actually the hospital's own and employees that they're reporting, and the money isn't actually going outside the organization. But you can get into the perverse situation where somebody says, I'm going to build $1 billion hospital building, and the community almost saying, gee, I wish it were $2 billion, then we get $100 million spent, when in fact, we as consumers ought to be worried about, can we afford the $2 billion and the additional operating costs? Because that's what our premiums can't really afford to support. So I'm just mentioning this to say that there's complexity, even for the consumers, to think about what's really in our broader interests. And I think what we're all talking about, and even Dale was talking about this, that because the basic affordability issues, the basic fact that hospitals sometimes used to put liens on people's homes when they had debts, the fact that the whole dealing with the insurance scheme, just the basic patient care and financial aspects is so challenging to people that many of us would say there ought to be community benefit associated with that whole effort, when in fact, we're talking about other things.
We got a lot more questions. Judith,
All
I'm
right.
going to throw one at you. When hospitals sell their bad debt to outside collection agencies, 20 cents on the dollar or whatever, do they get to count those losses as charity care or uncompensated care?
They're not supposed to count that as charity care. That's bad debt is a separate category on the IRS. Although I think hospitals would like to count all uncompensated care the same. And I think in an accounting perspective, it is kind of all the same. It's money the hospital's not seeing. But from our perspective, there's a difference between money that you're allocating for patients that really need it, that they can't afford it, versus money that you would like to get, but you're not getting. And to me, that's a similar idea to the Medicaid shortfall, why we don't count that, because just because a hospital is not getting money that it would like to get, that doesn't mean it's a community benefit. That's just money a hospital would like to get that it's not getting.
Yeah. Another one quickly for you, Judith. There's some new transparency regs brought to us by the Trump administration. What do you think? Have they helped?
So I'm not sure if the transparency is related to the hospital prices or transparency around community benefit spending through the ACA. I think in both cases, there's only so much that transparency can do. We're trying to bring a lot of it to light here with this report, but without any kind of teeth behind it about how much hospitals need to spend or any kind of minimum around that, it can only kind of go so far. So there's definitely limits to that.
Okay, here's another one for you, Jen and Paul. Can you share any of the most innovative or impactful investments that you've seen or heard about that make the community health improvement a real thing? Anything kind of strike you? Something?
I have one I would mention our state, but Jen, maybe you want to go first. Or
Probably the same one, but go ahead, Paul.
well, the collaborative one. So there is been an effort spurred by initially Boston Medical Center, who I think came together with Boston Children's Hospital, and I'm not sure, maybe the Brigham was part of this too. I'm not 100% sure, of doing something collectively around some affordable housing. And one of the great perplexing things to many of us is why hospitals and healthcare systems don't make more of an investment there, whether it's workforce housing for their own employees who can't afford to live close enough to get to the hospital to work, or affordable housing, which is a huge issue for our community. And there's probably ways for them to invest in that where they're not actually even giving money away, but maybe even having just a smaller rate of return. So it's still an investment. And I think it puzzles us. And some of us have said, well, do we need to incentivize that by saying if they can earn an 8% return for their money, but in affordable housing, it's only going to be 3%. Maybe they can, on their community benefits reporting, get 5% of that difference in investment return as credit. So, but I'll stop. But even though I'm lauding that one project that has gone forward, we're puzzled by that there hasn't been more of that effort going forward by other organizations.
And I'll just describe a little bit more about that project and what it looked like. It is a true collaboration that's happening that is rare to find in Boston. And they're building a grocery store in the neighborhood that currently does not have any nearby grocery shops for them. With the vendor that they brought in, the grocery store chain, they guaranteed a certain percentage, pretty high percentage, that had to come from the community that will be their employees at that store. They're building this affordable housing, and it's in a neighborhood that's getting gentrified, it's changing, and they are really working hard to make sure that that community keeps with the looks and the people that have been there for generations. And what I love about that is it's not just for their patients alone. It is recognizing that if our community is healthy as a whole, then we will have some downstream impact of that our patients will be healthier and maybe cost less. And so I think that's also something that we've got to get our health systems to look at, is not be so have such tunnel vision around thinking about just your patient panels and how you improve those costs, that if we can look at it as an actual community health approach, that then all boats rise, right? If we make the community healthier.
And whether it's carrots or sticks to get them there, that's a great example of them doing the right thing. And maybe that's what our gubernatorial or AG campaign folks can think about in this 2022 election year in our state too.
Thank you. So I'll pose this question to Vikas first and then to everyone. We have a question from the audience. How can we as employees handling community benefit reports and getting money out to our community partners encourage our hospital leadership to actually spend the amount they should? We would love to see this money put into the community, but hospital leadership is resistant.
Well, there's a lot of different angles. I think you have to approach this from those different angles. First and foremost, first of all, take this report and share it. It's getting scrutiny. It's getting noticed by a lot of people, including the media. So even if it were strictly from a PR point of view, it's important for hospitals to be aware of where sentiment is and where it's headed. Secondly, I really think, this was something that our advocacy wing, the Right Care Alliance, talked about a few years ago, and we may come back to this, which is actually trying to create a community-based effort to do what a few people have suggested, which is call on hospitals to pool all the resources and create a community-based health fund that truly is administered and and the spending is prioritized not by the hospitals themselves. But to do that, you really would need to partner with community organizations. So if you're inside a health system and want to see that kind of change, I think you have to do some sort of work with community organizations to make clear that, there's demand, there's interest, there's scrutiny, and there's a potential pathway forward with partners. So that's how I would answer that. Jen, you probably have other ideas too.
I just would add, and that the expectations aren't that they are operating the way a health system is operating. I think oftentimes when the dollars are being given out, it's the expectations, they don't have the billions of dollars to have the infrastructure and the capabilities that maybe you're able to pull as a health system. And so to recognize like there are strengths in different ways of operating, and your community organizations know what's best for the community. And so partner with them in a way that they can actually truly partner.
The other advice I would give, it sounds like it's a hospital employee who's a bit frustrated they can't move their own organization. Go find some champions on the medical staff who agree with you, and have them go and as an organized group to maybe talk with some of the hospital management, especially in a community hospital setting. You'd be surprised sometimes how far ideas can go that seemed that they weren't going anywhere before after you've gotten a group of the medical staff engaged on something. So.
Also, if your hospital is on the Lown Hospitals Index and you can compare with other hospitals, and if your hospital's maybe not looking as good as other hospitals, you can show that to leadership. Wouldn't we rather be higher on the ranking? That could be maybe be an impetus for change. So we have a question here. Speaking of hospital accountability, has anyone looked at the relationship between tax exemption and the commercial prices that nonprofit hospitals charge? This is not
I can
something
tell you in our state, there's no relationship. Meaning the highest priced hospitals, Boston Children, our state data agencies gives relative prices of hospitals. Boston Children's, the MGB hospitals are amongst the highest paid, and derive significant tax value from tax exemption as your own as the Lown Index or as the Fair Share Index suggests, at least on the MGB side. So.
Well, I can say, we have wanted to have commercial price data. We've sought it. You can get it for academic work, and you might be able to answer this question that way, but we had wanted it at the hospital level and the ability to actually identify each hospital and name them. And, to what Treasurer Falwell said, there is a cartel. We were unable to get that data. Even many of the nonprofits that have such data are legally bound or from their own business interests won't allow that sort of data to be used that way. So it's an interesting question, but we can't answer it right now.
It's baffling to me that that's allowed when 40% of your state budgets are being spent on healthcare, and how doesn't make sense to me.
Well,
You
the
would
real
think
problem is
that's
that 40% aren't these commercial
Right.
prices,
Yeah.
and so that's separate.
Maybe somebody needs to dig into it, but with the availability now of commercial prices paid, that's now, that could be an interesting data exercise across the country, I would think. So,
Yeah, it will come, although the early rollout was very, very slow because
right.
the penalties for non-compliance were trivial. It was a lot easier just to ignore it. I guess we have one or two last questions. Since other jumbo purchasers, such as employer-sponsored insurance plans, are so involved and impacted, what are you doing to disseminate this information directly to them? Well, we'd love to disseminate this directly to them. We've talked to a couple of purchaser organizations. We're such a small operation that we don't have a lot of resources to push there, but we'd love to do that. And so if anybody is out there in the audience that wants to work with us, do let us know. We'd be happy to. And I think we got to stop. This has been terrific. Again, thank you all. And Paul, Jen, thank you so much for joining us.